honor of welcoming you to And Justice for All with the Justice League. We're the third class of the Aspen Institute Health Innovators Fellows, a partnership with Prisma Health. This fellowship is a 2-year program that's quite competitive and takes 20 of our most innovative, mission-driven healthcare leaders across the U.S. Each year, fellows are chosen to strengthen their leadership and help broaden and deepen their impact on healthcare. So I know we have a few physicians in here, and we have people that are not physicians. And at this point, it really doesn't matter whether you are or aren't a physician. We do want you interested in healthcare. So as you heard yesterday from Dan Porterfield, he reminded us that a good society aims to be free, just, and equitable. And good health is central to that. We call ourselves the Justice League because our work addresses injustice in health, be it unjust conditions in American communities, inadequate treatments, activation of providers, or a health system ripe for revolution. So with that, let me introduce the first of our leaders. Saira Ramasastry. She's a managing partner of Life Sciences Advisory, an independent impact firm focused on new financial and business models to accelerate cures for patients in need. Formerly of Merrill Lynch, she's a thought leader on private-public partnerships and has worked with many groups on new models. So Saira, welcome.
During December of 2015, I was not in the mood for work. My husband was recovering from a close call with kidney cancer, and we were living in a tent thanks to a very prolonged house remodel. But a good friend called and insisted that I speak with his clients, Marcus and Paula. Their 10-month-old precious baby girl had been diagnosed with a rare and often fatal kidney disease called FSGS. She was in tremendous pain and put on a toxic regimen of immunosuppressants and steroids. There were no cures, but Marcos and Paula refused to just watch and wait. They wanted to find something for Pietra. I was hesitant, but how could I not help? Pietra is my mother's name. Both my husband and their daughter were suffering from kidney diseases. It was Christmas. It felt like a sign. So Marcos, Paula, and I joined forces to look for anything for beautiful Pietra. We formed research collaborations with leading institutions. We looked at biotechnology companies, but everything felt like a Hail Mary pass, with results not for decades and justified only by the lack of treatment alternatives. After months of searching, we found a different answer at the library. There's some preliminary research out of NYU that suggests that a specific kind of diet can benefit children with FSGS. Why had no one told us about this before prescribing those horrible drugs for Pietra? So we put Pietra on this diet. After a month, her kidneys had improved. And after 6 months, she was in complete remission of her disease and off her medicines. She is beautiful, and she is thriving 3 years later. We had to do something with this finding. Her doctors were amazed, and they called it miraculous. So we called researchers and scientists around the globe and found that there is a growing body of evidence that suggests, in the right circumstances, food can treat, prevent, and cure disease. And in that moment, we formed the For Life Institute, a mission that was inspired by baby Pietra and dedicated to the idea that food can be medicine. Our inaugural project was about Pietra. We invited 25 children, adorable, from all over the world with FSGS to come to Disney World for a summer camp setting. And we put them on this diet. We had nutritionists prepare all their meals and snacks, and clinicians looked after them for 30 days. We wanted our results to be taken seriously, so we pursued this with the rigor of a clinical trial. While Pietra's results were miraculous, we believe they were grounded in science. The results will be published soon, and the study design has been published. But we found that over half the children responded positively to this diet, and some are in remission of their disease just like Pietra. And all had a 70% reduction in a key biomarker that's implicated in many inflammatory diseases like severe asthma and rheumatoid arthritis. We want to inspire more projects in this area. There's so much evidence that is preliminary that suggests that food can be a treatment in the right circumstances for chronic diseases, metabolic diseases, and more controversially, cancer. At For Life, we want to catalyze projects in all of these areas and more in the long term. We also want to create a care model that puts medicine and food on equal footing in the patient care model. To do this, we are building care models and care centers in Brazil and in the United States in collaboration with Partners Healthcare. Now, to do this, we know we're going to need researchers who are brilliant and innovative entrepreneurs. So we're building an impact fund to catalyze ventures that are about our mission. We need to think differently about health. Pediatric drugs cost $400,000 a year, about $1,000 a day. They didn't work. Pediatric specific diet costs less than $10 a day. This works. In the United States, we spend $1.5 trillion every year on disease treatments. That's $15 per person per day in the United States. To put it in perspective, that's enough to feed everyone in the US 3 healthy, personalized meals every single day. I am in no way saying that medicine and drugs do not have their place in the treatment paradigm, but certainly these numbers show that there is room for evidence-based discovery. And even with these numbers, our system does not prioritize food. The word nutrition appears in the 2020 NIH budget overview 0 times. We need to think differently about health. Let's put food first. This isn't about choosing a salad over fast food. This is about food saving lives. Let's put life care in health care. Thank you.
Thank you, Syra. So next we have Lisa Fitzpatrick. You may have heard of her yesterday in Dan Porterfield's opening session. She is the founder of Grapevine Health, a company specializing in health literacy, patient insights, and engagement for Medicaid populations. Lisa is a physician, medical epidemiologist, and former chief medical officer of DC Medicaid. Lisa?
Good afternoon.
Good afternoon.
Thank you, Shami.
You're welcome.
Raise your hand if you've ever done something that scared you, even a little. I did. Soon after becoming chief medical officer at Medicaid, I learned that Medicaid patients miss 60% of their clinic visits. And I wanted to know why. But I knew I couldn't understand this unless I got proximal, so I did something a little scary. I moved out of my cushy, convenient condo in downtown DC, just a few miles away, to one of the city's poorest neighborhoods. I had to get proximal. And I learned 3 things are contributing to this low engagement: trauma, distrust, and low health literacy. First, trauma is embedded in the rhythm of the community where I live. And I'm not talking about just gun violence and robberies. I'm talking about subtle trauma that you don't even think about. But it's always there and it's distracting. So imagine, why would a healthcare visit even rank at the top of your priority list? Imagine what it's like to live in my neighborhood or a neighborhood like mine. You hear the constant sound of sirens. You're afraid to walk outside after dark. And if you hear gunfire, you wonder if it's someone you know. And after a while, these things become normal, and you don't even notice it. It's like a day I got on the subway, and the car was really rowdy. Lots of music and people shouting at each other. I became aggravated and decided to move to a different car. As the door opened, a little boy, and he couldn't have been more than 10 years old, got on the train by himself. He sat down and started playing a game on his phone, completely oblivious to the chaos right next to him. He probably grew up in this community. That chaos is subtle trauma, and endured for a long time, it makes you sick. And our healthcare system is not doing a good job addressing it. Second, distrust of the healthcare system is pervasive. I conducted a listening session at a men's homeless shelter close to my house. And I heard things like, we don't trust doctors because they don't like to take care of poor people. Or I can't understand what they're saying. And if I don't understand what you're saying, I don't trust you. But the most concerning thing I heard is that a person would rather die than go into a hospital for fear he'd end up dead anyway at the hands of a healthcare provider. And third, health literacy, low health literacy, is reinforcing the distrust I heard about at the shelter. My neighbor Joe was recently in the hospital, and he said, the doctor told me I have a weak heart, but there's nothing wrong with my heart. I feel good. So I said, well, why did you go to the hospital in the first place? And he said, well, I couldn't breathe.
Not related at all.
But then he said, but you know those doctors use those big words just to confuse you so they can pump you full of medicine. So guess what? Joe stopped taking his heart medicine. And shame on that doctor for not explaining in Joe's language why his shortness of breath was linked to his heart. But why is Joe asking me, his neighbor, about his health condition? A lot of people are like Joe. They trust friends and family with health information more than they trust doctors. How many of you have gone to the doctor and then immediately called a loved one to get their opinion or their advice? Happens all the time. So you see, I've learned a lot from my neighborhood, actually more than I've learned in 20 years as a physician and a healthcare leader about why healthcare engagement is so low. And I now understand why people in Georgetown, just 15 minutes from my house, live 21 years longer than people in my neighborhood. I also realized I was approaching this with a judgmental mindset. I was asking, why won't people engage in healthcare? And I should have been asking, why would they? So I'm using these insights to create solutions that will build trust, increase health literacy, and make healthcare less nebulous for people, less intimidating. And if you want to know more about what we're doing, please come up to me after, or you can find me on Twitter at AskDrFitz. But in the meantime, there's something each of you can do to help improve engagement for our most underserved. If you work in a health system, ensure your staff and the people who work in your organization are trained in trauma-informed care. And remember, there are probably people from neighborhoods just like mine who work in your institutions. How do you treat them? If you're a funder, demand feedback from at least 20 low-income end users. Find out if they even want to use your product before you give out money. And if you're a reporter, use the power of your voice and your pen to shine a light on how our healthcare system is failing our most vulnerable. So maybe you can't get as proximal as I did, but I hope at least I've inspired you a little bit, because there are neighborhoods like mine all across the U.S. Maybe I've inspired you to do just a little bit to help our underserved, even if it scares you a little bit. Thank you.
Thank you, Lisa. What that is a bit more scary than when I race BMX. It's actually far more scary. So next I have the pleasure of introducing Alan Voskanian, a family and palliative care physician. He's medical director at Cedars-Sinai Medical Group and an associate clinical professor of medicine at UCLA School of Medicine. Alan?
Great. Thank you, Shaman. So my father died last year. While losing a beloved father is difficult under any circumstance, knowing that his death was due to a medical error that was caused by a physician and that it could have been prevented makes it extremely hard to get over. My dad was 81 years old and he fell. Next day, the doctor ordered an x-ray, and after he reviewed the x-ray, told us that my dad was fine. Well, he wasn't fine. After a week, when he was still having problems, I called the doctor and begged him to review the x-rays again. That's when we learned that he had a hip fracture. This delay in diagnosis was the main cause for my dad's death. I know this physician well. He's a distant relative of mine. He's well-meaning, he's competent, but for many years, he has been overloaded, exhausted, and burned out. I had advised my dad to look for another doctor, but my dad didn't have the means and capability to listen to my advice. I can't stop thinking that if I had helped my dad find another doctor, he would still be alive today. Unfortunately, these errors are all too common because provider burnout has reached a very high level. Every single day, one physician commits suicide in the United States. That's 2 times higher than the rate of suicide in general public. Rate of depression and substance abuse is significantly higher amongst physicians who experience burnout. A recent New England Journal of Medicine Catalyst study showed that almost 83% of healthcare systems are experiencing provider burnout. To make things worse, burnout is very expensive, and the economic cost is $4.6 billion a year. When doctors are burned out, bad things happen. Burnout is associated with diminished cognitive functions and leads to errors that have devastating effects. Strong evidence suggests that physicians who are burned out are providing care that's more expensive, the quality of care is poor, and they're making a lot of mistakes, the error rate is higher, and the patients are less satisfied. Demoralized doctors also show less empathy and less caring towards their doctors. And also they lose that joy in being a healer. Burnout can also reduce the enthusiasm of doctors who want to work with the poorest and most vulnerable patients. I would like to share one story of how this happens. A young physician graduated from medical school in early 2000s, late 1990s, towards the tail end of the HIV epidemic. He was passionate about providing care to HIV-positive patients who were often abandoned by their families because they were gay. So after many years of training with over 100,000 in debt, he chose to practice at a non-for-profit clinic where he made significantly less compared to other opportunities. He loved the work. He felt like he was making a difference every day. He had joy in his practice. But then, slowly, he started losing that passion. He felt like he could not spend enough time with his patients. He was spending more time on the electronic health record, doing a lot of clerical works. I think that sounds familiar to some of you. I see you're shaking your head. After 3 years in this practice, He felt like he was not making a difference. He started to feel depressed. And shortly thereafter, he left that practice. This is only one example, but unfortunately, I know many similar stories amongst my colleagues. We are in the middle of an epidemic of burnout. We are all very familiar with all the acute problems that we face in our healthcare system, the high cost, the poor quality, and the depersonalized patient experience. But there is a more silent epidemic, and that's physician burnout. Now, I know most of you who are not physicians are probably thinking, so what? We are all burned out. Everybody's burned out. Get over it. Like, come on, stop whining. But physician burnout is actually 2 times higher than the burnout rate amongst our general workforce. And also, as I mentioned, when physicians are burned out, there are significant problems with the burnout. With a crisis of this proportion, you'd think every health system would have a comprehensive evidence-based plan in place. But shockingly, that's not the case. Programs are piecemeal, and there's little evidence that they're effective. Sometimes we blame the physician because it's easy to do so. We think we can solve the problem by asking them to do 3 things: meditate, do yoga, and eat more granola. We need a paradigm shift, an innovative approach for resolving this problem. This crisis compelled me to create a comprehensive initiative that gathers all the evidence about what works to address the root cause of burnout and to develop a multi-pronged, evidence-based approach to tackle this issue. We are currently rolling out the first iteration of a multi-year plan that I and my colleagues and fellow physicians developed at Cedars-Sinai. We will study burnout and figure out what works and what doesn't. When we find the evidence that something works, we'll expand and spread that throughout our healthcare system and to other healthcare systems. I am very optimistic that we can tackle this issue if we put our mind to it. On another optimistic note, that story I told you about that doctor who left the nonprofit clinic, it has a happy ending. It's close to home. It's my story. After leaving that nonprofit, I decided that I did not want to be a statistic, and I wanted to be involved in fixing the problem. My ask from all of you here is to take physician burnout seriously. Have more empathy towards your physicians. Stop blaming them, and work with your physicians, engage them to develop a comprehensive approach to address this issue. It's my goal that none of your dads or moms or relatives will ever experience a devastating error that's caused by a physician that's burned out. Thank you.
Thank you, Alan. And now I have the pleasure of introducing Rushika Fernandez-Poulet. He's co-founder and CEO of Iora Health, a national primary care group. An author and practicing physician, he is also on faculty at Harvard Medical School. Rushika?
So imagine for a moment it's 1902, and instead of being in this beautiful setting in Aspen, we're in New York City. And what we want to do is we want to get to London, and we want to get there in less than a day. The problem, of course, is all we have are ships, and even the fastest ship takes a week to cross the Atlantic. So what we'd be tempted to do is maybe call all the shipbuilders together for an ideas conference, maybe a little bit like this. We would study the tides, we'd try to streamline the hull, we'd try to build faster engines. We know now today that that's a waste of time, right? What we need is not a faster ship, what we need is an airplane. And the simple fact is the way we build airplanes is not by putting wings on ships. We build airplanes. So I would postulate that we're at the same point today in healthcare. As my colleagues have pointed out, too often our system is not serving us well. So as Ira pointed out, we're skewing how we treat things to expensive chemicals when often things like food or relationships might do better. As Lisa pointed out, particularly among the underserved, we too often don't listen to people. We're not asking the questions and we're not engaging people, and we blame the victims when outcomes are poor. As Alan pointed out, the experience of care, as I'm sure all of you know have ever tried to go through the health system, is too often suboptimal, and it's not just for patients, it's for doctors and other people serving people. And we're doing all of this at a cost that's sort of obscene, that's actually robbing us of all of our wage growth. It's bankrupting cities, states, individuals, and will bankrupt our country individually. So I think it's foolish to think that we can fix these big, deep problems with small incremental tweaks, but that's what we spend most of our time doing. I'm a physician. I spent most of my career doing this small incremental change, putting wings on boats. About 15 years ago, I decided maybe we need to start over and try to create some new models and create bigger change. The fundamental problem, I thought, was that what we've done in healthcare in the US is we've turned it into a series of transactions. Document, code, bill, next. And a lot of the things we do to try and fix it just simply add more transactions, meaningful use, medical homes, ACOs, they're all just more checkboxes. Last I checked, transactions have never healed anyone. The thing that heals people is relationships. And what we need to do is get rid of the transactions and rebuild a system on the basis of relationships. So I started a little company. It was originally called Renaissance Health, the rebirth of primary care. By the way, it's a bad idea because I can't spell Renaissance. So we now call it Iora Health. And the idea was let's build a new model of care from the ground up, starting with the patient, the consumer, the people, and build up, not down from hospitals. We changed everything, changed the payment model, you got to change the IT systems, you got to change the culture, change the process. Let me just give you one example. We realized that the system should not be centered around us, doctors. We're important because we diagnose and we treat. That's not the hard part. The hard part is how do you help patients execute on the plan, much as Lisa talked about. So we created this group of people about 15 years ago we call health coaches. They're people from the community, speak the language of the people they serve. They're chosen for one thing only, which is empathy, connecting to human beings. And their idea is that they can help patients understand their condition and execute. They ask questions. You can ask questions of them. They can take you grocery shopping to learn how to shop, take you for walks, hold your hand when that's the right thing to do, and to be honest, kick you in the behind when that's the right thing to do. So we've been doing this for about 15 years. We now have 50 practices across the country, 12 different markets, and the outcomes are phenomenal. Patients and doctors love this system. Our outcomes are better than almost every other practice in the country. We're reducing hospitalizations by 40%, ER visits in half, total spend by 15%. We're putting money back in people's pockets. We had a practice we did with casino workers in Atlantic City, and we were able to give people a 50-cent an hour raise because you're able to lower the cost of healthcare. But I don't think this is a solution. It's the right first step. So the question we have to ask is why do we have only 50 practices, and why do the few other people out there have about the same number? Right? And I think the question is not about ideas, it's about power. So what we've done is we've allowed the creation of what I call a medical industrial complex. It's a series of institutions that, to be honest, are serving their own interests and not necessarily ours. So we always point the finger at pharmaceutical companies. There are some egregious pricing and things that are going on that are now coming to light. But it's also people like us as doctors. Too often doctors being paid fee for service with a vague fear of malpractice or ordering tests and procedures on people they really don't want nor need. One doctor put it very crassly to me. He called a patient my little ATM. I can print money with this patient by doing things to them. Too often hospitals, having spent a lot of time with health systems, even the nonprofit ones, are too busy filling beds and building more MRI machines and not doing what their mission statement says, which is actually improving the health of the community. Right? Doing nothing to actually do that except as lip service. Health plans, despite the rhetoric, make basically a percentage of money off the top. Guess what? A percentage of a bigger number is a bigger number. Right? So the system is all geared to serving its needs and not ours. So one of the folks we read in our seminar was Martin Luther King, letter to the Birmingham jail. He said, history is the sad and tragic story of the fact that privileged groups rarely give up their privilege voluntarily. Yeah. So I would postulate that if we really want to fix healthcare, what we need is not tweaking the boats, but we need to actually have a social movement to really take back power. So what do I mean by that? I think we have seen over the past century a number of very successful social movements causing real change in our society. Think Occupy, think Black Lives Matter, think a number of the independence movements like going on in Hong Kong right now. Think about the marriage equality movement, causing change that we never would have thought happened and that didn't happen because people in power voluntarily gave it up. So what can we do? This is going to be a long journey. It's going to require many of us, not a few of us. So the first step is individual action. I would argue we all need to learn more about the healthcare system. Unfortunately, the more we learn, the more disappointing we get. But radicalization is the first step. I think the thing we all can do is ask questions. Ask questions of our doctors, our hospitals, our health plans, to our employers. And by the way, if they don't give us good answers, or when more likely they don't answer the question, vote with your feet. Right? Vote with your feet to people who do. Eventually, what we're going to need is collective action. Stay tuned. So the Institute of Medicine, back about 15 years ago, said that the gap between the quality of care that we have and we could have, but between the quality of care we have now and what we could have is not a gap, but a chasm. Thinking we can cross this chasm by making small tweaks to the system, I think it's fooling ourselves. It's time we get the courage to learn how to fly. Thank you.
So thank you. As you can tell, though it might have sounded trite when I said it at the beginning, we do consider ourselves the Justice League. We do feel like we are working against injustice in our health system. So with that, we would like to open it up for questions. We have about 13 minutes at most. Can I grab some water? In the back. And please introduce yourself and tell us where you're from.
Thank you. This is Andre Blackman, founder and CEO
Can
of
you
Onboard.
stand up, please?
Oh, yep. Andre Blackman, founder and CEO of Onboard Health. We're building a diverse and inclusive workforce ecosystem to power the future of health. And I'm from Raleigh-Durham, North Carolina, that area.
Yeah.
Yes. So, yeah. So for Lisa, so with our age of misinformation, word of mouth, social media, a lot of that kind of going on, like what exactly are some things that you're doing to mitigate that around health literacy and how you're translating that into action as well?
Yeah, thank you. I started a company called Grapevine Health, and the purpose of Grapevine Health is to help educate Medicaid patients. So we're working with two Medicaid managed care organizations right now to improve patient engagement and understand what's driving some of the healthcare behavior. But if you zoom out bigger to look at what we ultimately hope to do is to drive people to a digital solution they trust, because I believe the future of healthcare, even for underserved communities and low-income patients, is outside four walls. Everybody's got a phone now, including poor people. People still ask me that. Do poor people have phones? Do they have access to the internet? They do. And we would love to build trust so that we can drive them to this solution to improve their engagement in healthcare, to answer their questions, provide medical decision support. But right now, we're just building the brand by being out, listening to people, asking what they want and need, what their concerns are, and feeding some of that information back to their managed care organizations.
Hello, everyone. My name is Reagan McDonald Mosley. I work at Planned Parenthood, and I live in Baltimore, Maryland. Thank you to all of the speakers. That was really, really amazing. My question is for Rushika. I love the idea of changing the paradigm from a transactional system to one that's based on relationships. Can you talk a little bit more about what that looks like and what that, how you do that work? Thank you.
Yeah, so let me share a story. I have hundreds of stories of patients that we've interacted with. And so it was a practice we ran, and I walked, going to see the patient. The health coach came out to get me and said, "Doc, this patient is a hot mess." And so I walk in the room, and she was. Her hair was disheveled. She had this blank look in her eye. Her name was Joyce. She had diabetes and hypertension that she was not treating very well. She was eating awfully. She was not taking her meds, in and out of the ER. So we met her. She got a health coach. We started coming to some groups we offered. I ended up leaving that practice to try and figure out how I scale this and get more of them. I came back 6 months later, and the doc who took over for me, Neil Patel, said, Rishika, remember that patient the first day, the hot mess? She's back. I want you to meet her. I was like, great. So I walk in the room, and I don't recognize her. She looks amazing. Her hair's combed, a little makeup on, glint in her eye. She's taking her meds. She's eating differently. Her A1C was down to 8, which is almost normal. Her hypertension's under control. And I was like, Joyce, you look amazing. And she said, thank you, doc. I've never felt better in my life. So then I asked her a question. I was like, Joyce, what have we done to help you? And she said something very profound. She did not say, you have a good business model, you have a good IT system, you have good protocols. She said something very profound. She said, Doc, you all cared about me. You taught me to care about myself, and I didn't want to let any of us down. Right? You cared about me. You taught me to care about myself. I didn't want to let any of us down. Right? That's the sharp end of the sword. That's the relationship. That's what changes healthcare. All this other stuff is fluff. Now, we have to get it right, because if we don't get it right, it makes it hard to do the right thing. But I think we lose that focus too often in healthcare. Build the relationship. The rest will follow.
Hi, everyone. I'm Yael Lehman, President and CEO of the Food Trust, and I'm based in Philadelphia. My question is for Alan. I would imagine that when you talk about this high suicide rate for doctors and their burnout, I would think that they would be very closeted about that there would be a lot of pressure for them to always seem in control. How do you break down the barrier and actually get them to open up and say, hey, actually, I need support?
Yeah, thanks for that question. So actual depression rates amongst physicians, it's very similar to general public, but physicians, one thing that's different is that physicians are less likely to talk about depression with their fellow colleagues or family members due to the stigma. So one initiative that we started is called Meet and Eat. And it started as a way to break down social isolation. We bring a group of physicians, of about 6 to 8 physicians together on a regular basis, and we subsidize for their lunch. And it's an opportunity for them just to meet regularly, talk about life issues, to mentor each other, to be mentored, and share their experiences. Social isolation is a very big deal amongst physicians.
You in the back?
No, this one here. Here's
Oh, there.
Okay.
Hi, my name is Shireen Gabriel. I'm a physician. I'm president of Rush University. My question is actually for Rishika. You talked about the health coaches. Could you give me an idea how you recruit and train and support the career development of these obviously critical individuals?
It's a great question. So we try and find folks from the community, right? So we actually network, and we partner with people like Lisa who are in neighborhoods we're going to be in, and try to introduce us to people. One of our early investors and one of my mentors is Tony Hsieh, the CEO of Zappos. And I think one of the cores that he taught me is if you want to build great institutions, you have to first think about building great culture in the company, and then people will treat people well. In healthcare, we often treat our employees like crap, and then we are surprised they treat their customers like crap, right? Well, no, that's what happens, right? So we said, how do we pick people? We use what's called speed dating, right? So we just have a lot of people come in and meet 6 or 7 of us, and we just say, teach us something you know, and teach us anything, and tell us about your life. And you can pick up pretty quickly. Empathetic people fairly quickly find other empathetic people. But we did a random study where we tried to pick people through resume screening, and then through this model, and we were much better using this model. All resumes do, by the way, is screen for people who actually write resumes well, right, which is almost incredible. We then have a 4-week sort of training program to bring people up to speed. And then what we do is we have sort of an apprenticeship model where you, first of all, you get people, you watch what other people do, and then you'll be watched doing it, and then you can do it yourself, and then eventually you teach it. That whole process takes about 6 months. So then what's important is you have to have a great retention program, right? So we create a career ladder where people can go and become senior health coaches, master health coaches, and the like. One way you can think about what we're doing, by the way, these are great jobs. These are people otherwise would be working at Target and Sears or a fast food restaurant. One way to think what we're doing in an economic development term is we're putting a few cardiologists out of work who are doing unnecessary CATs. For every cardiologist we put out of work, I can hire 10 health coaches. I think that's a good trade.
Thanks, Rishika. There was a question in the back. If you want to go ahead and start as that microphone gets to you.
I'm Jennifer Tesher, and I run an organization called the Financial Health Network. So I'm thinking about a lot of these same issues from the financial health perspective. And my question is really for Lisa and Rishika. we heard Lisa say, I think the future is in your hand, right? That this is the mode. We've heard Rashika just say, I think, essentially, I think the opposite. I'm putting words in your mouth, right? We face these exact same issues and thinking about financial health. My answer is generally, it's probably some combination of both. But I would love to hear you both talk about that issue of how do you balance tech and touch? And because I'm a fan of both, of course, but when's the right time to use it? When is the right time where you really need a human engagement?
I think you're right. There is a balance. But for the population we're focused on people who have no interest in engaging in healthcare. They sit in the emergency room for hours, and they don't mind because they want situational healthcare. Help fix this issue I have right now. Don't talk to me about going to a doctor a month or 3 months from now. And for those folks who are completely disengaged or mostly disengaged, I think finding a digital solution that allows you to connect with them could potentially move them along the continuum. I'm a public health doctor, so I'm very focused on prevention, something we are abysmal at. So what if we could get people to think about small changes they could make along or in the prevention sector, and then later they may see value in having a primary care provider. So I think it is a combination, but I would love to see us take healthcare to people. So a good example is we are working with a group that's going to help us get into a public housing complex so that we can build relationships there so that they have a go-to source because they may not want to go to the doctor.
Rashika?
Yeah, so I completely agree. So I think that we make a mistake in healthcare when we think about, we start with the technology and go backward. So what's your telemedicine strategy? Like irrelevance, what's your improving health strategy? Thinking that the question is how do we get computers or phones to replace doctors is a stupid question. It's what's the problem is build relationships, improve health. What's the role of people in that and relationships, and what's the role for technology? And the obvious answer when you ask it that way is it's both. We believe strongly, particularly for the bulk of the problem today is chronic disease. And that chronic disease is best managed in a long-term relationship. Now, there's a huge role for technology. It is silly, like in the current fee-for-service world, to make people come into the office to be told their lab results. People do this all the time because that's how they get paid. It's a waste of time. It's a waste of time to have people come in once every 3 months to get their blood pressure. By the way, the blood pressure you take in the office is irrelevant because people are scared and they're rushed. We need to figure out the numbers they're getting at home, and then we need to interact with them. So again, the right question is how do I fix the problem, and what's the right role of technology?
I'll get to you in 1 sec, but Sarah, I do have a question for you.
Okay.
You're on a panel with 3 physicians. We use evidence all the time, but we have spent 2 years with you, and many of us thought food might have a role in medicine, but we weren't quite sure. How do you intend to convince us and other physicians and other people who aren't quite sure food makes a difference that food does?
We aim to scientifically validate this through projects and studies. So for example, with our study, it was called the GENIE study that we did with the children with FSGS. We partnered with the Harvard hospitals. We wrote a protocol. We ran it all with the rigor of a clinical trial. That's what we need to do. We need to run this just like you would a clinical study for pharmaceuticals and have a science-based result.
Is there still a question in the back that I said I'd come back to, or no?
Yeah.
Right there.
I'm Kurt Malkoff. I'm a PhD clinical psychologist who owns a company called Matrix Psychological Services. We essentially provide mental health services to about 600,000 lives, companies like Victoria's Secret and hospitals and what have you. At any rate, my question is, how do we train physicians differently? You have to start at the medical school, I think, because we're using a 1940 model of training all you folks. What are some ideas of breaking that paradigm?
So I'll start. I think you're exactly right. We are training physicians.
Stop there.
And we'll be brief. We will be brief.
We're training physicians for a job that doesn't exist anymore. I think, by the way, we can't think that it is really important, but if we don't change the downstream, they're going to think this, they're going to get in, they get their butts kicked when they go to residency, and it gets beaten right out of them. So we have to do both and change the training and change the system.
But I think we also have to pressure organizations like ACGME, AAMC, the folks who are influencing curricula, because right now institutions have to decide what they prioritize in the medical school curriculum. So I'm on the faculty at the School of Medicine at GW, and we have a program that's specifically trying to help students understand a lot of the issues we've been talking about. We didn't talk about social determinants today, but we are also trying to expose students to some of these issues as well, so that they're thinking about it from the first time they see a patient. So I think it's a long time coming, especially if our policy bodies aren't on board with what you're talking about.
So I want to thank you. I've been given the official sign of 0 minutes left. All of us are more than happy to talk to you as they take our mics off and let the rest of you go. But again, thank you so much for your time. Remember, justice is important in healthcare, and we're here to serve you as the Justice League. Thank you. Yes.